It's Tim from ChiroUp. It's Friday afternoon. That means a couple of things. Number one, we're done with patients. Number two, it's Friday Live with the docs. And for a second week in a row, it's Doc Singular. Dr. Steele's out again this weekend, so I'll try to give you something helpful to use. I think that this has been a great week for chiropractic. There have been a couple of studies. If you're a subscriber, you can check out your news feed. There was a BMJ article, British Medical Journal, that showed 250,000 patients, and that data said that out of physicians, medical providers, chiropractors, and physical therapists, chiropractic had the lowest opioid use. And then later this week, Pain Medicine Journal said that using chiropractic care for musculoskeletal problems cuts opioid use by 64%. That's huge, especially at a time that right now the ACA is making a hard push to make sure that you and I are classified as physicians in Medicare and that we're reimbursed appropriately. This isn't the first studies, it's just been a good week. There's lots of other data from the CDC, the Department of Defense, the FDA, state attorney generals that have said chiropractic care can be a solution to the opioid crisis. And one of the things that we apply in the treatment room so effectively is spinal manipulation. Really, I consider that my magic hammer, that if I had one tool that I could use, certainly it's spinal manipulation. A lot of times here at ChiroUp, we talk about all the other tools that we use as far as home exercises and different types of rehab for the patient, our physical therapy modalities, nerve mobilizations, and all those things are great things to have in the toolbox. But I want to be clear that if I had one tool, it would be spinal manipulation. Unfortunately, that magic hammer is not perfect, that there are times that spinal manipulation may not even be appropriate. That when a patient has lower back pain, oftentimes it is a hypomobility, but the question we want to answer today is, what if it's hypermobility? So we have Ashley with us, and Ashley's going to help us with this, that there are instances that a patient may give us signs that they may appreciate stability exercises as opposed to mobility manipulation or mobility exercises. Oftentimes that patient is young, typically they're under 40. The one caveat to this is that if someone has degenerative spondylolisthesis, they're probably not under 40, they're probably well over 50, into 60 or 70. And that patient, by definition of spondylolysis and spondylolisthesis, is going to have instability. So that's the one exception. Otherwise, patients who like stability are generally young, usually under 40. The other thing that we're going to look for is somebody who's usually hypermobile. So oftentimes that's a hypermobile female or sometimes a male, but more commonly a female. In that hypermobility, one way we'll assess that is through the straight leg raise. So actually, if you lie down, typically we know that patients, especially young active patients, are usually going to stop somewhere at 60 or 70. But if we can get that patient up to 90, that's great. If we can get them beyond 90 degrees, which we're not going to do in this case, then that tells us this patient may have hypermobility, that they're just a little bit laxer than the average patient. So maybe there are other things in their spine that are lax, as well as their hamstrings and muscles and capsule of their hip. The other thing that we're going to look for is, how does the patient breathe? Because remember, our spinal stability arises from our ability to pressurize our canister being the diaphragm on top, the pelvic floor on the bottom, the transverse abdominis, and then our deep lumbar muscles like the multifidus and the superficial muscles like the erectors. So when all of those are working in concert to pressurize the canister, things work well. But all too often that canister is opened and unable to pressurize because the diaphragm's not contracting. So when the patient's lying on their back, we're watching how they breathe. And if we need that accentuated, we have them put one hand on their belly, one hand on their sternum up top, and we watch which hand moves. When Ashley takes a deep breath, we're going to see that hopefully just the hand on her belly is going up and down, and the hand on her chest is staying very still. Most patients don't breathe like that. They have a dysfunctional pattern. They don't have great chiropractors who teach them how to breathe properly, and they'll breathe with an upper chest pattern where the upper chest is moving and their belly's not moving at all. That tells us the canister is not stable to start with. So that's another clue. One of my favorite tests, though, to determine is this mobility or stability is the PA shear and the prone instability test. So we have this patient lie on their stomach, and when they're on their stomach, one of the things that we're always going to do is we're going to palpate the joint, right? We can call it motion palpation to see how it's working, but if we apply a pressure through the spinous or through the facets, there's going to be tenderness generally if there's a problem. And the only thing that tenderness tells us is that there's a problem. We don't know if that's a hypomobility of a restricted segment, which all too often I assume, or hypermobility. That's an unhappy segment because it's moved too much. So the way that we differentiate that, we do the PA shear test, apply a couple of pounds of force at L5, L4, L3, and L2. And let's say that Ashley said yes, at L5 there was tenderness. Now what I want to do is find out what happens if we create some artificial stability in the area. So the way that we'll engage those deep lumbar muscles, the multifidus, is to have Ashley bring both legs up off of the table in a locked fashion and apply the same pressure. When I'm doing that, and then you can relax again, and Ashley says now that's less uncomfortable, that I'm more comfortable when I have my legs up off of the table, that tells us that this patient is going to appreciate stability and not necessarily mobility, at least at that segment. That doesn't mean that her sacroiliac joint might need to be moved, or L4 or L3 or whatever segment else was involved, but it tells us that segment certainly is calling out for some stability as opposed to mobility. So next time we have a patient that comes in, we've adjusted them 3 or 4 times, they're not getting worse, but they're really not improving. They're young, they're possibly hypermobile with a straight leg raise. We apply a pressure that then goes away when that patient takes their legs up off of the table, and I shear that. We know that that patient is probably a stability patient. Now the actual formal test for that is having the patient come up and then lie over the edge of the table here. So go ahead and come up and hang on to the table. So we'll get this a little bit higher. The way that this really should happen is Ashley's up on the table, I do the PA shear. Does that hurt? Yes. Does this hurt? No, no, no. Okay, now lift your legs off the table 6 inches. Now does it hurt at L5 where it was painful before? No, it's no longer painful. So that's the real test. But let's face it, in practice, we have to be efficient. The future of healthcare means great outcomes, high patient satisfaction, but at a lower cost, at a lower reimbursement level. So that lower reimbursement level means we need to be as efficient as possible. I'll always screen the patient first with them lying prone, and then if we need to transition to this variety, we can. But if your table can't come up like this, at least you have a tool that you can use. The other things that we're going to look for in addition to those are, does the patient have a hitch? That patients who have some degree of instability often complain of a hitch in their back or a hitch in their get along. And that's going to be assessed simply by having them flex forward. When they go into forward flexion, is there an aberrant motion pattern? Meaning that instead of going straight forward and straight back up, they work around something on the way down. Or when they're coming up, they get around that hitch and work themselves up with their hands. That's a strong clue. So when we see young patient under 40, unless it's degenerative spondylolisthesis, a straight leg raise that goes above 90 degrees, a PA shear that becomes negative when we have them do the prone instability test, lifting their legs off the table, and this patient has an aberrant motion, we're very certain that they need stability. So the question is, what do we give them for stability? We'll have to look towards Stu McGill, really the godfather of spinal stability. And he would tell us that in addition to teaching that patient how to breathe from their belly properly, we're going to give them the big 3 or 4 exercises. And those exercises are, number 1, the dead bug. So we're going to have the patient lie on their back on a flat table. We're going to have them then bring one arm up over their head, and then at the same time that they bring that arm together, this knee comes up bent at 90-90 here. So we're going into this position, and then back down again, and come up into this position, and back down again. We can do that 10 repetitions on one set of opposites, and we're doing opposites because that's how we move throughout life, that when one arm moves forward, the opposite leg moves forward. The 2 things that are very important for this exercise are, number 1, we sometimes want to have a little bit of an arch in the lumbar spine. So we want to maintain the lordosis by having that patient put a little bit of a cushion, a pillow, or their hand underneath it. And number 2, we want to teach them how to do this exercise while pressurizing their canister, pressurizing their abdomen. So sometimes if we put our hands on the patient, can I put my hands here? And we're going to push in a little and have them resist. And right now Ashley is resisting out. So she's pressurizing that canister. And with that pressurized canister, now can do it with the opposite side of the left arm and the right leg and bring those 2 together. So pressurizing together. Back down, head stays nice and relaxed. Upward and back down. So that's the dead bug. Most anybody can accomplish the dead bug. The next couple are a little bit more challenging, and we'll go to a different, more stable table to make that happen. So we'll go next door. The other exercises are going to be a side bridge, or we're going to have that patient get into a side lying position. They're initially going to start in just a little bit of a fetal position, so that a little bit of flexion. We want them to imagine that they've been placed on a skewer that goes through their head and out the tail. So that skewer is going to hold their spine in a nice neutral position. We're going to make sure that they're pressurizing, and then they can start either from their knees in this instance and come up and back down, and then forward and up. So try no rotation of the trunk. We want to keep this nice and flat, and then back down, and then up, and back down. When the patient can do a side bridge from this position, then we'll see if they can get all the way out to their ankle. So we're going to have them straighten their legs and then come up into the side bridge here. So that's really nice. Again, Ashley's got good form. A little bit of twist of the pelvis, which we don't want. We want that nice and straight, but she's keeping her head nice and straight, chin tucked in. And then we're also going to do a curl up. So the curl up on her back. And with the curl up, this is very different than a sit up. We're going to have them in a single hook lying position. So one foot comes up, the other stays down. We're going to have them again support their back. We're going to have them pressurize their abdomen. And pressurizing doesn't mean sucking in, it means pushing out. If we want guy wires on a telephone pole, we want them out, not in. So we're going to have that patient pressurize their abdomen, keep breathing, a little bit of a chin tuck, and she's just rolling her shoulders up off of the table and back down again. And rolling her shoulders up off of the table and back down again. So that's the curl up. And then finally, the last one is the bird dog. So actually, you're now on all fours again. And one arm, both arms down, and at the same time that you're going to bring your right arm up, the left leg is going to come back. So pressurizing, and just a touch higher here. And one thing that she's doing really well here is that she's keeping her leg below the plane of her hips. That if this leg comes way up, what's that facet patient going to say to you the next time they come in? They're going to say, my back is really sore, because they've been jamming that into extension. So we want that to come up to there and then back down all the way to the starting position and back up again and to the starting position. We want Ashley to keep her pelvis as stable as possible. We want that pressurized abdomen as she's doing that, and go ahead and do that as though I'm holding you, not quite as high, perfect, and then down. And your head should be just a little bit straighter, chin tucked in just a little bit, and now let's go. Perfect, and back down. And then 10 in the opposite direction. Now, some providers choose to prescribe this with the same pattern, 10 this way and then 10 this way. Others prefer to do a cross crawl where 1, 1, 1, 1. What I'd love to hear is what's your opinion on that? Which one do you prefer, and what's the rationale for that? I hope that this information has been useful. I hope that Ashley, your back feels good as a result of it. I hope that it's something that you can apply on Monday morning, and we'll look forward to connecting next week. Thanks for watching.